All right, unmuted myself. Good evening, everybody. Thanks for taking time out of your busy schedules, whether you're watching this live or you're watching this on recording. We all know vet med does not slow down, whether it's summer or any time of the year. So thanks for taking time. And my thanks to Zoomatica for having me with y'all. It's appreciated. Um, so appreciate the kind introduction. Couple of disclaimers. I work with a lot of our industry partners. I also work with a number of 501c3s like Paws of Honor and Hurricane Heroes. None of them had any review or oversight or input on any of my intellectual property, but just a disclaiming that I work with a bunch of people. What are we going to cover tonight? Okay, so what I really want to kind of get into here is being practical and fundamental. I deal with all the complex, weird stuff, but we all know that well, you may not know, but less than 10% of dogs or cats in their lifetime will see a veterinary specialist once. Okay. So think about all the animals that you've all seen already this week. Okay. 1 out of 10 will get to a specialist in their lifetime on average, which means 90% of them never will. And if 50% of those patients have arthritis or other mobility disorders, okay, 45% of your caseload is on you to figure out how to diagnose and manage. Okay? Now you can absolutely always post on VIN or email a colleague. You're not alone in these, but if you're in private practice, whether you're in rehab or not, you are the diagnostician for mobility. Right? So what we're going to cover tonight are some fundamental physical exam findings and baseline diagnostics for shoulder issues, LS disease, and OA in general. We're then going to cover the use of shockwave. We're going to compare it to competition out there, and we'll get into some evidence review as well. Well, the outline's going to flip. I'm going to cover my experience with shockwave, and then the hour will probably end, but if anybody wants to stick around, I will continue to talk about my feelings about Librela. So with that in mind, let's jump right in. The most expensive piece of equipment in all of veterinary medicine is you, okay? The hours of student loans, the hours in the library, the hours tonight taking time out of your busy schedules to keep learning, okay? Your hands, your brain, your eyes put everything together. So it's the physical exam that is critically important. And so we need to be doing a good, solid physical. Um, that includes fundamentals, right? Weight and body condition score on every patient every time they walk in the building. TPRs, right? Yes, of course. I've had dogs come to me for arthritis that have 6 out of 6 murmurs, right? I'm like, I think your dog can't walk down the street, not because its joints are painful, but because its heart doesn't work, right? So doing a solid physical. I've had dogs come to me for lethargy and arthritis and getting old, and they have lymph nodes the size of my fist, okay? So we have to do a good solid physical, including a rectal exam and a neuro exam, right? Flipping feet over, doing a couple of quick reflexes, making sure the neck moves and the low back, which we're going to get into obviously with LS disease, is important because not everything that's mobility is orthopedic, right? So we need to make sure we know what we're treating so we know where to treat appropriately. Then in the orthopedic and musculoskeletal, if you're doing these already, fantastic. If you're not, reach out to me. I'll help you get these set up for your practice. We can learn a lot from our equine colleagues. They do a lameness score on every patient they see, and they have a validated system that is consistent across all equine practitioners on Earth, okay? Or at least within North America with the AAP system. We do not. We need to be better about communicating and writing this stuff down. We need to be using pain scores. Yes, if you have stance analyzers, goniometry, yes, you can get into all sorts of fun stuff in the rehab and sports med world, but palpation is still what it comes down to. So with that in mind, let's talk about the shoulder itself first, okay? Shoulder kind of gets overlooked. Most thoracic limb lamenesses are elbow in origin, but what I really wanted to focus on was some of the things that may not be, right? The elbow feels all normal, it's great. What's going on with the shoulder? The three big things we see in shoulder disease are arthritis. It's going to be bimodal. It's either going to be early on with a shoulder OCD lesion or later in life with OA. We're going to see tendinopathies, which we'll get into, right? Especially with sporting dogs, agility, Schitzen, all sorts of other activities. These dogs are going to wear out their shoulder tendons more from chronic repetitive stress. And of course, yes, right? Osteosarcomas away from the elbow and towards the knee. So things that are going to be painful in the shoulder could be more painful in the proximal humerus. And then thankfully, hopefully, we're seeing less shoulder trauma, hit by cars, things like that. But if you have a dog who's painful in the shoulder, if you don't get good rads, how do you tell the difference, right? Because on the far right, tiny little shoulder OA spur right here on the caudal humeral head, and a little bit of mineralization at the caudal glenoid. Right? Middle one, little shoulder OA off the caudal humeral head, but all these mineralized bodies are right along the biceps tendon. Right? So this is chronic biceps tenosynovitis. And then, of course, the one on the left, hopefully we don't see that often, but that moth-eaten lytic lesion of the proximal humerus is our adversary osteosarcoma. So when we think about the shoulder, we have to remember that dogs don't really have a functional clavicle. We're talking about the glenohumeral joint, and we need to be honestly thinking about these from the fact that most of the shoulder tendinopathies can be secondary to elbow OA. But if the elbow doesn't hurt, it's not effused, and it has a completely normal range of motion, the shoulder can still be a primary problem. And while I say shoulder, what I've already done, if I'm thinking about the shoulder, is I have felt the entire scapula, and you guys need to do this too. You feel the entire scapula, make sure it doesn't hurt. You find the spine of the scapula, trace it up and down. It should always be a straight line. If the spine of the scapula is not a straight line, take scapular radiographs. And go back a film here, right? All of these have the distal aspect of the scapula on there, because I've already known that the spine of the scapula is a straight line and the proximal scapula doesn't hurt. If it hurts, I could be missing a scapular osteosarcoma or an old tumor or an old fracture or something else that's a cause of pain. So make sure you feel the entire scapula, and if something hurts in the proximal scapula, get rads of it. As we do that though, right, these tendinopathies, tendinitises are often chronic repetitive stress injuries, the dogs that play a lot of fetch or tug of war. And if you look at this working police dog who came into my clinic, right, look at his hind feet. His hind feet are square and he's pointing all his toes forward. His left front foot is also square, his toes are forward, and he is offloading that right front and is outwardly rotating his toes. He's telling you when this dog just stands, it goes, meaning this dog may not limp, right? But that dog is standing there going, this doesn't feel great. When we're thinking about shoulder tendons, the big five that I'm thinking about are the supra, the infra, the biceps, the teres minor, and the subscapularis. Most commonly, the supra and the biceps are the ones that are commonly injured. Shoulder tendinopathies have some degree of atrophy, but they're not hugely atrophied, and they are not usually non-weight bearing. Now, in this picture, what I've done is I have flexed the shoulder and then I have extended the elbow. And as you can see, even on this fuzzy dog, that paw is up near its butt. Okay, that is abnormal. The radius and ulna should not be parallel to the spine. Okay, this is what is called loss of end feel, okay, because the entire biceps tendon is ruptured. There is nothing holding that on anymore. So that's a simple test. We're going to find out what it is. We're going to figure out what happened and how to make it better. With these, when we do that bicep stretch, we have to first flex the shoulder alone. That's going to test the supraspinatus and infraspinatus. Then we're going to extend the elbow, and now we engage the biceps from a shoulder flexion position. Everybody always talks about, I put this old picture up here where let's poke the dog right on the medial insertion of the biceps tendon. Okay, if that dog's awake, right, that left hand is near what? the dog's face. You're going to get bit if that hurts. Or anybody pokes you in your back when you've thrown your back out. You want to react pretty hard? Let's not do this. Okay? I haven't pushed on a biceps tendon in probably 10 years, if not longer. Okay? I extend the shoulders, I flex the shoulders, I do bicep stretch. Right? I look for things like the dog holding its breath or wincing or turning towards me. Right? I'm not trying to aggravate something here. What basic diagnostics are we doing for shoulders? Physical, sedated, radiologist reviewed, orthogonal RADS. Right? And if you're not sure or you think both shoulders hurt, great. Get both the left shoulder and the right shoulder individually. You may not see everything, but you saw in the slide a couple of slides ago what I can see just from plain films. We've ruled out big bad things like osteosarc. We can also do musculoskeletal ultrasound. There are pros and cons to that. It's a steep learning curve. Not everybody does it, but it is a beautiful way to do dynamic assessments of the tendons. And I've done that for years. There's a lot of folks out there doing it more, and it really gives us a great understanding because it is way less expensive than anything on the right side of this slide, right? CT, very, very helpful, but you may not have access to it. MRI, nano arthroscopy, needle arthroscopy, of course, gorgeous and wonderful, but you may not have access to it. If you've done a solid physical and gotten RADS, maybe an ultrasound, we've eliminated osteosarcoma, we've eliminated elbow OA, the carpus doesn't hurt, there's no neck pain, the neuro exam's normal. This dog's got a shoulder tendinopathy till proven otherwise. And from some very basic diagnostics. Moving on to one of my favorite diseases of all time, lumbosacral disease, LS disease. This is degenerative. I'm not talking about discospondylitis or neoplastic processes. But this is known as sciatica in people. So raise your hand if you've ever thrown your back out, right? We have nerve root compression, right? On this, usually between L7 and S1, because that's the most highly motion area of the entire spine in the caudal part of the dog. This is extremely important, right? This is a working police dog who is, okay, I can search low, right? But I want to search high, and the moment I search high, I want to get back down, right? Because my back hurts when I search high. This dog is trained to hold that search for 5-6 seconds, and as you can see, what are we holding, right? Let's go up 1,000, 2 1,000. Yeah, I want to get back down again, okay? So sometimes if you're dealing with dogs, police dogs, that you may say, hey, we have a performance issue. The dog doesn't want to work anymore. 9 times out of 10, that's not it, okay? The dog hurts when it works, so it's refusing to work. Pet dogs, reluctance to jump, pain when rising, pain during activity, okay? Getting old, I love that one. The dog got old. Okay, when did age become a disease, right? Or the techs, right? The technicians ask, hey, when was the last time your dog went upstairs? Oh, it doesn't go upstairs anymore, he got old. I'm sorry, that is not true. Right? The dog hurts when it's going upstairs because it's extending its back. And the other one that'll be out there is dogs that squat to poop, right? They will either, well, they're all dogs squat to poop, but they either will start waddling while they poop, or they won't stay in one position. Because again, when they go to squat, their back hurts. Clinical physical exam on these dogs, okay? You've already checked stifles and hips and everything else. So we're going to do dorsal to ventral palpation of the LS space, just like finding where a spot to put an epidural needle is. So that's top left picture with my right index finger is right on the LS. Top right picture, I'm finding the greater trochanters and I'm just rocking back onto that sciatic nerve and pressing on it. Sometimes the dog will be painful there, or the hamstring muscles will start to quiver. I will always do a rectal exam on these dogs because I've had dogs that have LS-like pain that have agasakas growing, right? Because there's just a space occupying uncomfortable area in that pelvic area. We tail jack them, right? So this is the bottom left picture. Raise the tail all the way up, right? Can you? Does the dog wince? Does the dog stop panting, right? And then if we really need to hyperextend the LS, that's the bottom right picture. Also, and I'll show you this videos in a second, we check the withdrawal reflex. The withdrawal reflex tests the sciatic nerve in the pelvic limb. And so all three joints should flex, the hip, the stifle, and the hock, immediately. In early or mid-stage LS disease, you will start to see, before sometimes even pain at the LS, before dogs, some dogs are just really stoic, right? But they can't fool their electric wiring. So you pinch their toes and the hip flexes and the stifle flexes, but the hock does not. And that's a sciatic neuropathy, and that's telling you this is probably LS disease. So watch what this is. This is not me holding that hock in extension. That dog can't flex it because the neuropathy is bad enough that it can't tell its hock flexors to engage, which is why that dog shuffles down the hallway. And then look at this nice golden retriever, right? I push on his LS, he licks his lips and he turns towards me. Okay? Old video when we all wore masks all the time in the clinic, right? Lift the dog's tail, right? Licks its lips and moves away, right? I'm not using a lot of force, really happy dog, but simple tests. Remember that our differential is going to include, of course, degenerative LS disease, but we need to be sure we're not dealing with disco or neoplasia or fractures. And just as a friendly reminder, obviously your thoracic limbs are going to be normal and you're going to have lower motor neuron deficits, usually for L4S3 disease. So what do? Right? The hips are normal. So let's take some radiographs. Maybe, is it hip dysplasia or LS disease? In this radiograph, what would be on the left side of the VD, so the dog's right hip, yeah, that dog has femoral neck widening, osteophytosis. That dog has radiographic hip OA, but that hip does not hurt at all. And this dog is atrophied in its left hind leg, which barely has any OA changes. But look at the LS junction with all this remodeling, with this big step lesion. And then look at the VD, and you see it as well at the L7S1, okay? Much narrower disc space than L6-7 or L5-6 on both the laterals and the VDs. And with radiographs, we've now looked at this and said, hey, we don't see punctate lesions. We don't see multiple myeloma. We don't see blatant obvious disco. Yeah, we haven't ruled out all the things yet. We're not as great as a CT or an MRI, but we've done our fundamentals. Also, please, please, please count to 7, okay? Always take pelvic radiographs and go all the way up to T11 to make sure, because dogs should have 7 lumbar vertebrae. And I counted this dog. I went all the way up to T1 and counted. This last rib is on T13. This dog has 8 vertebrae. Look, 1, you can see my mouse, 2, 3, 4, 5, 6, 7, 8. This dog has 8 lumbar vertebrae with LS changes, right? This is a 2-year-old dog. This is a congenital malformation called transitional vertebrae, which I will get into more in a minute, but you have to count. I've also seen 6, right? It's just going to put abnormal stress on the spinal cord. Yes, it would be lovely if we can get these dogs to look at them on CT or MRI. This is what we're going to see. But again, for practicality, we're going to stick to plain films. Those transitional vertebrae are critically important. Okay? In this lateral radiograph, look at the fact that the sacrum is not fused. Okay, this is a sacrum that is not fused, so there is wobbliness. Right, there's mobility in that sacrum that's going to press right on those sacral nerves. Right, transitional vertebrae can happen to the lumbar vertebrae. They can happen to the sacral vertebrae. They can be extranumerary. They can just be misshapen. But any dog with a transitional vertebrae is 8 times more likely to develop degenerative lumbosacral disease. And also they are at higher risk for developing hip dysplasia. Because since you have an abnormal vertebrae, you're putting abnormal stress on the ilial wing during development, which then puts abnormal stress on the coxofemoral joint. Dogs with a lumbar transitional vertebrae will develop LS disease 1 to 2 years earlier than normal dogs. This is huge, okay? On the VD, look at on the top right arrow, there's a transverse process to the one side. There is not on the other side. Okay, this dog not only has inappropriate numbers of vertebrae, but they're misshapen. It's going to put horrible stress on this dog the moment it's 3 months old. This is critically important because LS disease is the #1 reason why any working canine is retired early on Earth. Look at what these amazing dogs do during training. Okay, none of this is on the job. Okay, if you ever want to get hit by a mountain while running 30 miles an hour, trust me, you don't. And that top left picture is an 85-pound German Shepherd clearing a 5-foot fence. That handler is almost 6 foot. Okay, you do not want to be hit by one of these dogs. Right? They put it themselves. These are the true Olympic athletes versus where horses are and human Olympic athletes. These dogs are going through multiple repetitions of high intensity, high impact exercise. They're putting their lives on the line to protect us. And yes, there's a genetic component of LS disease too. So we just have to be careful with this. But this is why LS disease needs to be found more. Okay? If anybody wants to read it, this is the Worth et al. Paper from a couple of years ago now. That is a fantastic review of degenerative LS disease. Highlighting the breeds commonly seen, yes, of course, German Shepherds, but also Dobermans, Rhodesians, Great Danes, Labradors, and Greyhounds. Okay, so Greyhounds can have perfect hips, but they can still have crappy LSs. Okay, so you can do a good job finding these. Right, that review article showed that more male than female dogs have LS disease. I think that's not right. I think it's just that a lot of working dogs work male dogs. Because I look at my pet population of LS disease that I diagnose, and it's nearly 50-50 split male and female. But in that Worth paper, 27% of police dogs in New Zealand retired or euthanized due to LS disease. I'll say that again, 27% of police dogs were retired or euthanized due to LS disease, right? In fact, they were trying to get them to just 8 years of age, so work for 6 years, and they were retiring at age 6.6 because they were so painful. So they redid their entire breeding population, their entire training, and now they're much better, right? OA, right? If you worked today and you saw 10 dogs, you probably saw 3 out of 10 are going to have OA, right? We're not going to talk about septic arthritis or neoplastic arthritis, but degenerative OA, right? These radiographs are from a 2-year-old Labrador patient of mine. Look at how nasty that elbow is. Okay, this dog was bilateral. And this is not just in the US. This is a paper out of the UK going, what's the prevalence of elbow disease? Right? Rotties, Labs, German Shepherds, and Goldens were their top 4 breeds. That makes sense with what we see in the US too. 1 out of 5 dogs had trouble exercising. That's that 20% in the middle. 3 out of 4 owners said their dog was lame. Okay. But only 1 out of 7, 14% said their dog was painful. Now, I'm sorry, if the dog is lame, the dog is most likely painful. Okay. 61% of cases in the study were bilateral. And the elbow disease contributed to the decision to euthanize 41% of the dogs in this study. And I am sorry, we did not get into vet med to put down middle-aged dogs from arthritis pain. Right? No way at all. Okay. What do we see in the US? This was a paper out of NC State recently that said, hey, dogs that come into the primary care facility at NC State, if we just take radiographs on young dogs, just looking for it, do we see, how much OA do we see? Well, we see a lot, okay? Elbows and hips were the number 1 and number 2 joints, respectively, that had OA. And look at the number of dogs under the age of 18 months. 20% of the dogs in the study were under 18 months and already had radiographic OA. So don't tell me this is an old dog disease, right? In fact, they stopped their limit at age 4, right? 57% of dogs at age 4 had OA. This is bad. We can do a lot better with this, right? We all get taught that OA is a cartilage disease, but yet cartilage does not have nerve endings. We all get taught that too. So why does arthritis hurt? Because the synovium has the most amount of nociceptors. It's the synovium that feels pain and transmits that to the brain. It is the synovium that provides nutrition to the joint and makes joint fluid and protects cartilage. Okay, so arthritis is not a cartilage disease, it is a synovial disease. And it is that chronic synovitis that starts usually from instability, right? Hip dysplasia, laxity of hip dysplasia creates a synovitis, creates a vicious cycle of inflammation, right? It's an immunomodulatory disease, and that is what then leads to tons of pain and inflammation, and then literally creates battery acid out of the joint fluid, which eats away at the cartilage, causes more pain. We get to bone on bone, right? This is a nasty disease, and this has to be thought of as organ failure, right? The joint is an organ. The synovium provides the nutrition for that joint, for that organ. And when you have chronic end-stage arthritis, you are an organ failure, right? So if you're finding these, right, do good exams on juveniles, on dogs, on cats. Ask questions, right? This will not OA, this slide says OA and DJD. I meant it for actually to be like, you can find these for LS disease. You can find this for shoulder tendinopathies, right? Feel for joint thickening, for muscle wasting. Look for scuff marks, right? Flip over their toes, right? I get it that GP is super busy, but go outside and watch the dog walk if you can, right? Feel the dog. Remember, you have one of the coolest jobs in the world. You get paid to pet animals every day. Right? Pet them not only on their back and on their head, but feel all their joints, bend their joints. If one is asymmetrical to the other side, that's a clue that something's not right. Right? Take radiographs. None of us were born on Krypton. None of us have X-ray vision. And I showed you, we could miss an osteosarcoma or something else, or a septic joint. Look at these horrible hips. This is a 2-year-old Labrador, right? And also, by the way, guess what? That's his elbow, right? How's this dog going to walk? This is because, right, we are rarely being proactive. We are usually being reactive. This was a paper, this is Jones 2023 out of Frontiers, that reviewed just what imaging, just from imaging, not arthroscopy, but from any imaging modalities, when can we detect OA? And on the bottom, right, on the green is when the disease is reversible all the way on the left, and end stage, irreversible, painful on the right. And look at where CT and RADS catch this disease, when it's already in the painful and irreversible stages. So we have to be managing this. How do we manage? Pain meds, right? NSAIDs, amantadine. I put question marks next to the others because we don't really have a lot of evidence for pre-GAB opioids or GABA. And Librela and Silencia is an interesting topic that I'll try to get to tonight. Okay, if we're managing these dogs with shoulder arthropathies or LS disease or OA, nothing beats achieving lean body mass and daily low impact exercise. Yes, we can be including all these other modalities, which we're going to cover. But I will tell owners, I can shockwave the heck out of your dog's joints, but if your dog has a BCS of 9 out of 9, and you're not putting it on a diet, I'm not going to win. Your dog's not going to win. Okay? We have to get this dog to a lean body mass. How can we track success? Right? This is the CBPI, the Canine Brief Pain Inventory. Okay, this is a validated, simple 11-question scale that you can have an owner fill out. Now, if there's 2 owners, the same owner has to fill it out every time. And you can track how the dog is able to do at home, right? From functional testing, from the owner's response. So you have them fill this out at every consult and every recheck, right? And you compare the numbers. You average questions 1 through 4, you average questions 5 through 10, and you look at the averages over time. And this is completely free. You can all download this tonight. There's the website. So here's the opportunity, okay? I did GP for a decade before I went back and did my residency, okay? I love mobility, clearly. I didn't like giving vaccines or treating ear infections anymore, okay? Maybe you do, maybe you don't, that's entirely great, right? But if you're the only doctor in the practice, you still need to be addressing mobility. Or if you're in a 10-doctor practice, maybe you can do what I did when I was still in GP. I saw all the mobility stuff and I passed off all the dentals and ear infections and stuff like that to somebody who really liked that in my practice. But the opportunity presents itself that pets are living longer. We can also diagnose this earlier now. Owners don't want necessarily drugs. And we didn't, just like we didn't get into vet med to euthanize 6-year-old dogs from arthritis, we probably also didn't get into vet med to push pills. So why not have a new skill? Why not be able to go back and go, hey, I can work on the mobility aspects of my patients in this practice? What can we learn? All of these things are One Health problems, right? OA, LS disease, shoulder tendinopathies occur in dogs, cats, horses, humans, zoo animals, okay? So what can we learn from equine? Equines use shockwave for decades, right? So there's an opportunity here for all of us to work together. So shockwave, we're using high energy sound waves to create a cellular response. That's going to stimulate new blood vessel formation, stem cell recruitment, collagen remodeling, even have anti-inflammatory effects and pain relief. Right? Contraindications, don't want to use it over open growth plates, over an immune-mediated disease, infection, cancer, of course. We need to be safe over, of course, unstable fractures and surgical implants. A shock wave is an abrupt change in pressure with a velocity higher than the speed of sound, right? It vibrates, hopefully not like the earthquake at 8.8 that sent tsunamis out today, okay? There are two types of shock waves. There's radial pressure, which doesn't penetrate very well and distributes over a wide area, and then focused shock wave. Focused shock wave is either generated through piezoelectric, electromagnetic, or electrohydraulic origins, and you're focusing it right at the targeted tissue. So electromagnetic uses electromagnets, electrohydraulic uses a spark, right, and creates a focused wave. Piezoelectric, right, uses a different system. But unlike ultrasound or laser, we don't lose any energy on tissues like skin or fat when we use shockwave, right? And the tissues don't know how the shockwave is produced. They're just responding to those pressure waves, right? Minimal pain, right? As long as the focus is not at the skin level, right? We need to focus it to the area that's uncomfortable, right? So focused versus radial, okay? There's pulse vets, the electrohydraulic system, the piezo wave and impact and curative sound are piezoelectric systems, right? Focus systems have deeper penetration, higher energy, and a broader treatment area. Or radial, like I said, much lower cost, but you're treating a much smaller area and much shallower. Okay? There were 2 research papers that I found on radial shockwave on hips. It helped in the short term, like for 30 days, I think. Okay, so not very well, not very long. If we're comparing what's out there in the research, okay, and me, I am evidence-based, right? So I need to know, not only does it work well in my clinic, but what have others done with it? What's the science behind it? And that counts for shockwave or nutraceuticals or anything I do, okay? Piezo wave, focus shockwave, non-sedation, okay? Very technical to use a little bit. Takes a little more of a learning curve on those, but they have 2 research papers out there. Honestly, the shoulder tendinopathy one was not a very strong paper, and there was an elbow hygroma paper. Curative sound system, there's 1 safety study on dogs, okay? The impact system, no clinical research on this device at this point. Okay? It just came out this year. And I pulled an electromagnetic one that's not available in the US, but it's available in Europe. There's no papers that I could find on it for dogs. So in this example, right, I'm also looking, going, we don't have I didn't pull all the equine or human papers, really just looking at what do we have for evidence in dogs. Because honestly, unfortunately, we don't have any evidence in cats. So the Versatron or Equitron system is the older names for the pulse vet. The electrohydraulic generation creates the deepest penetration. And it already has 8 research papers out in dogs, covering tendinopathies, covering fibrotic myopathy, covering stifle OA, and actually showing improvement in TPLO recovery. Okay? And I think I have a slide in here about it. We'll talk about LS disease as well. So you have a true focus shockwave, right? Powerful, consistent energy. And I'll be honest, so this device has been out on the market for a long time. Historically, you always had to use it under sedation, okay? They came out with a new trode, right? So a delivery system for it that'll avoid sedation in 85% of cases based off of a paper came out of Colorado State. Some may need some calming drugs, food distraction, things like that, but we've really been able to use this now in the hands of my rehab practitioners and not necessarily just with me, because if I have to use something under sedation, I have to have a tech, we have to sedate the dog, we had increased costs, right? I have to be treating, I have to be there because we were sedating it. Okay? Now with the Xtrode, we really have that flexibility. If you haven't used it, the helpful part about electrohydraulic is it's really done 1 to 2 weeks, maybe 2-3 weeks apart, right? 1 to 3 sessions. So they don't have to come in weekly, like some of these other systems may need. And this is what I'm using it for, right? Obviously OA, LS disease and shoulders, but we're using it as part of our post-op rehab for TPLOs. We're also using it, of course, for elbow OA management. And you can also use Shockwave for wound management as well. So laser is not the only option for wounds. Historically for Shockwave, like I said, up until a couple of years ago, we really had to be sedated. We should be clipping and cleaning the area ideally, so we get really good penetration. Okay? For electrohydraulic, we're dealing with about 500 to 1,000 pulses per treatment, which takes a whopping 1 to 2 minutes, maybe a little bit longer. Okay? Historically, it's loud, recommending use of earplugs if you're sensitive, not only for people, okay? Sometimes some dogs are reactive to it. I'll put cotton balls in their ears, right? Which we also use, we put in ear protection for all dogs getting an MRI in our hospital, okay? So we want to protect those ears. You can do the same thing. There's some dogs that are just not going to react to the noising. What's the evidence for PulseVet? This is an older paper by Kristen Kirkby Shaw and her team that looked at the PulseVet system for shoulder tendinopathies in 29 dogs and found 85% of dogs had good or excellent outcomes, anywhere from 11 weeks to 220 weeks after therapy. Okay, so 4 years in some cases. But it did require sedation. This is a paper out of Tufts vet school that looked at it again for shoulder lamenesses in dogs. They did 3 treatments, 3 to 4 weeks apart, and also found good outcomes. Leilani Alvarez at AMC did a really nice review article on Shockwave recently. This is some of the tables from there, just showing where do we go with energy, where do we need sedation, what can we be doing with these? The clinical care points from the bottom left. Aim for at least 2 treatments, 2-3 weeks apart. If you're not seeing improvement after second treatment, are you doing it right? Are you setting it right? Or maybe this is the dog that it doesn't respond to, and that's okay. This is in review. Okay, this is a pilot study done out of Ohio State's vet school using the PulseVet system on the older system where they did have to sedate, but they did specifically use it looking at LS disease. They did 3 treatments, day 0, day 14, and day 28, and did a recheck at day 60 and found that that the vast majority of dogs had improved. Okay. Owner perceived improvement was reported for 6 out of 10. And I think veterinary scores were actually 8 out of 10. But can we use it practically, right? I said all these were systems that were requiring sedation, but it's the same technology now with the Xtrode. So this is the paper out of Colorado State's vet school that looked at 40 client-owned dogs with diseases of hip, stifle, elbow, shoulders, okay? Using the newer Xtrode from Zoomatica and finding that the dogs did not react to it, right? They were able to safely use this wide awake in 85% of patients. Video proof of that. This is the Xtrode in our clinic, okay? Unless you listen to the sound for a minute, right? We're doing 480 pulses a minute. We're going to do 1,000 pulses on this dog, okay? I'm not going to let this play the whole time for sake of brevity, but what I want to point out with this, see if it comes back up to the dog's head, okay? This is a boxer, okay? Oop, let me back that up. Hold on. Okay, this is a boxer who was labeled as evil, will bite, caution, muzzle, requires IM sedation. Okay, does this dog look sedated to you? Okay, nope. Okay, this dog had seen a behaviorist, okay, for its aggression, and the behaviorist, after seeing it, right, sent it, called them and told them to come see me, and behaviorist called me and goes, the dog only bites and growls when you touch its butt. And I'm like, cool, right? Dog is completely non-reactive if you touch it anywhere else. Did a physical exam. Dog has L4-S3 myelopathy. I could do a full physical, but if I touched that dog's LS, he totally lost it and growled at me. Okay. Dog had impaired hock flexion on its withdrawals. Dog had a completely normal physical otherwise. I talked with the owners. They've been battling this for 3 years, right? So this dog, we did do an MRI because we wanted to confirm it, okay? This dog has raging LS disease. She has 8 lumbar vertebrae, and she has both 7 and 8 are malformed, okay? So this dog is not behavioral. This dog hasn't been in chronic pain since it was 6 months old. What I did was, we did the MRI to confirm it, but she's a young dog, and they were like, look, we want to confirm it, but we don't want to do epidurals. We don't want to do surgery. I said, that's fine. Put the dog on carprofen, brought it back 10 days later. I could touch its LS without any problems on carprofen. Nobody had ever tried pain meds on this dog. So we did shockwave, wide awake. This dog's out like 9 months now off carprofen, and nobody hasn't growled at anybody. Okay? You didn't miss, the MRI was a nice touch in this case, but it wasn't a requirement. We could have done this off of plain films. This dog, shoulder, this is an agility border collie, okay? Has been told sound reactive, cannot be touched, right? Totally freaks out. So what did we do? We fed it, okay? We did not shave it. We greased everything down with coupling gel. But we were able to treat this dog's shoulder tendinopathy, got back to competition within a matter of a month or 6 weeks or so. Cats, okay? This cat is wide awake. This cat is not even on gabapentin. Yes, I have made a burrito with it, okay? We're treating this cat's horrific elbow arthritis wide awake because this cat sees our internal medicine service. And when I tell you this cat sees our internal medicine service, I'm telling you this cat has IBD, CKD, and chronic cholangiohepatitis, okay? So this cat can't take any meds. Everything pisses it off. So this cat has horrific elbow away, treating it wide awake. So I want you guys to ask yourselves, are we seeing cases that aren't responding to Librela or NSAIDs? Are we worried about Librela adverse events? Do your clients want non-drug options, right? Make a diagnosis, right? Find out why they're not walking right. The whole point of the human-animal bond is to have an animal around in good quality and good quantity. We need to be the advocates for doing that. Whether that's sporting dogs, pet dogs, working dogs, cats. I think I've made a decent case enough tonight that we really can do this with a solid physical and baseline diagnostics, and you can incorporate a targeted approach relatively easily. I'll be honest, right? I think that the X-Drode is the easiest one to use. I've used them all. Right now, I love the fact that I only have to treat every 2 or 3 weeks. Most of my treatments are done by my techs following up. We do them all wide awake. Okay. Of course, we always need more research. I also think it's worth it to pair up things like the Assisi loop with it so the owners can treat at home as well. If anybody has to jump out, what I thought we could do is I want to give you my direct contact info. I give credit to my dogs, Penny and Aurora, who are in my office with me and not bugging me right now during a webinar like they usually do. If anybody needs to ask some questions, I'll gladly answer them. If anybody needs to jump out, I again thank you for taking time out of your busy schedules. Right? There's all my citations. And while we're getting set up for any questions that may be there, here's my personal experience, right? 90% of my patients I can do wide awake, right? 5% of them do need sedation. Nothing's perfect. Why don't we open it up to questions then? If not, there's no questions, and we don't stick around. I've got a few more slides. to cover.
Okay. Thanks a lot, Dr. Brunke. We'll give everyone just a few minutes. You can type your questions in the Q&A box there, and we can answer those live while we have Dr. Brunke with us this evening. While we do that, I will just remind everybody that your CE certificate will be emailed to you within the next few days. So keep a lookout for that. If you don't see it, check your junk or your spam folder. Sometimes they do end up there. Also, this evening's webinar is being recorded. It will be available and posted on the zomedica.com website under the Learning tab. If you want to go back and rewatch or recap any of the great information that was provided here this evening. Dr. Brunke, I see one first question that came through. Any discomfort during treatments? It looks like no, but I'll let you elaborate on that.
Yeah, I think we have a couple that may be a little reactive initially, and we'll lower the frequency of the pulses, or we'll lower the energy setting down for a little bit, and then ramp it up, almost kind of creating like a continuous rate infusion, and just slowly ramping it up. And that seems to solve. I can't think of one we haven't had a problem with lately, to be honest. We're probably due for one that we have to sedate, but no, really, any of them, of course, with any of these targeted treatments, they might be sore the next day. I don't let them just go home and run around like lunatics because they've been dealing with stuff. So some of them may be sore for a day or two. If they're already on an NSAID, I leave them on it for the first treatment or two, and then I try to back out the NSAID because we're going to give the shockwave time for it to do its effects to the tissue.
Okay. Next question. This is a pretty extensive topic, but can you provide the top few things an owner or a vet can do preventatively, since OA is often not detected until it is an irreversible stage?
Do a solid physical, and for example, for puppies, remember that pen hip x-rays are validated down to 16 weeks of age. So I can do a pen hip, you can do a pen hip at 16 weeks of age and know exactly what that dog's risks are for hip dysplasia. And you have to set them up that we're managing diseases, right? Short of joint replacement, we're not curing these diseases. So just because they have end-stage radiographic changes doesn't mean they're end-stage clinically, right? Those don't always correlate, but we have to set them up that we're not curing this, we're managing it.
Okay. Let's see. This attendee says, I've looked at PulseVet as well as other shockwave devices. The settings have been an issue. How do you determine how to use this?
That's an interesting one. I haven't really had that problem. I have done all the math on the presets that you guys have put into the PulseVet, and everything matches to the research. So I honestly use the presets. Maybe that might be something better to, if you guys have any input. I haven't come across that problem yet.
No, yeah, we've not either. But I know if you want to look into that question a little bit further to our attendee, send that question to info@zomedica.com and we can get a more of an expert answer for you there. Let's see, going on to the next one. Do you recommend shockwave when you have radiographic OA changes, but no obvious clinical findings, as in maybe they're not lame?
Well, they may not be lame, but oops, I don't want to go ahead too far. They may not be lame, but what are they functional? Okay, so functionally, right? They may not be lame, but everybody do me a favor. Sit back in your chair and raise your arms above your head, right? If you look up, okay, most likely one arm goes up higher than the other, okay? So if you're middle-aged, you probably have some degree of OA, okay? So I'm looking for functional changes, right? Can the dog sustain shoulder extension for 5 seconds? It can do it in its hip, but it can't do it in its shoulder. That dog has pain and discomfort, okay? So comfortable range of motion is critically important, and sustained flexion and extension is critically important. And if it's asymmetric to the other side of the body, you don't have to wait for it to be lame, okay? It's already telling you it's chronically painful.
Okay. Our next guest says, I treated my own dog who has elbow, hip, and stifle arthritis. She was very uncomfortable. After the second treatment, she was great for about 24 hours, but then we had a complete reversion. Any suggestions?
And I would still do a third treatment. And then the hard part is if you have multiple joints, right? It's maybe pick on the one or two that are the most painful and try to bring those down. And then a couple of weeks later, go after the next set of joints. I always feel bad for dogs that are affected in all four legs, because if everything hurts, they just want to lay on their back like a turtle. Um, so I would go back to that, but pick out maybe the ones that are more painful. And I would also make sure that, if you didn't shave, make sure you're using tons of ultrasound gel. Make sure you're moving the trode, right? And maybe that's when you try, instead of an E6 setting, maybe you try E4 for the first treatment or two, and then try to ramp it up. Maybe that dog is already in a hypersensitive state, right? That's a little bit of a tough one.
Okay. Let's see. For a 2-year-old dog with 8 lumbar vertebrae and discomfort, defecating is currently managed with Adequan injections and chronic gabapentin use. Would ESWT be a good option?
Yeah, absolutely. It
Okay.
was a simple answer. Yes.
All right. Next one. I was told not to use a shockwave over the spine, but you used it over the LS junction, including centrally where I'm having trouble reading this. Cauda equina traverse. Do you use it further up over the spinal
Yeah.
cord?
Yeah, I would use it as long as I don't have a recent hemilaminectomy site where the spinal cord is technically exposed. I have no problem using shockwaves we use it for wobblers, we use it for T3L3. So if the cord is exposed, that's a different story. If it had recent hemilaminectomy or ventral slot, that's different. But otherwise, no, I think we're good.
Okay. Let's see. Here's the next one. I didn't see any mention of supplements. Are you an advocate of starting glucosamine at first stages of joint disease? And can they help show progression of joint disease?
Well, the topic tonight is not was not nutraceuticals. I could do a whole nother hour just on that. There was a 2022 review paper. So if you plug into Google 2022 dog joint supplement glucosamine, okay, the first thing that'll pop up is a paper out of the University of Montreal's vet school that is a systematic review and meta-analysis that no longer recommends the use of any glucosamine or chondroitin supplement, as there is not enough evidence to support it, right? OA management is complex. I do think that there's a lot of good nutraceuticals out there as far as things like UC2 and eggshell membrane, but that's and omega-3 fatty acids. But point of tonight was not to cover into nutraceuticals.
Okay. And then this question came through. This person is asking, how are you charging for multiple joint treatments, as it does tend to get expensive?
Yeah, that's a good question. We kind of treat, I think we do 1 to 3 joints for one price and then 4 to 6 joints for another price. So if we have to treat both shoulders, especially because it's going to take, if the dog's really good and we're doing it wide awake, and I have, if we're doing 1,000 pulses at 480 pulses a minute, my total time is 6 minutes, right? 4 minutes of treatment and a minute or two to get the gel on and get the dog in position. So we're pretty flexible on 1 to 3 joints for one treatment, but others may price it differently.
Okay. Great questions here this evening. I've got the next one here. How long do the shockwave treatments work or last? After the 2 to 3 treatments, do they have to be done again periodically, or not
Yeah,
unless the patient develops symptoms again?
yeah, it's when are they painful again, right? So with anything, right? Like if I inject a joint, right? Some dogs it works for 9 months, some dogs it works for 6 months, some dogs it works for 12 months. So where there's the state of the disease, if the dog's morbidly obese, right? The dog has to lose weight. They have to go out and do exercise. They can't just, just let the dog sit on the couch and do nothing. So we're gonna, if I have to retreat again in 6 months, that may be reasonable. I think that's a reasonable enough outcome if we're dealing with chronic disease. If we're dealing with some sort of acute tendinopathy, then we may be 3 treatments and done. It depends on what the disease that we're treating.
Okay. We have a few more minutes left. Let's see. So if you have to treat again, do you do one treatment or do you do another 2 to 3 sessions?
I would probably do another 2 or 3.
Okay.
Huh?
All right. We've got a few more minutes. Dr. Brunke, did you have other slides you
Yeah,
wanted
I
to
do.
show?
Yep, I'm gonna hop in. So I think it's really helpful to pair things. I like multimodal treatments. By that meaning, different things have different mechanisms of action and tissues heal differently. So I actually really complement a lot of our shockwave treatments with things that owners can do at home. And there's good evidence on using pulsed electromagnetic fields, which we'll cover in a minute. We use them in all sorts of different ways. Here's that little Italian greyhound has not neck disease, actually has shoulder OA. So we actually put the Assisi loop over its head, and we can treat both shoulders in one simple treatment. The dachshund, of course, with T3L3 disease, we use it like a hula hoop. And then the loop lounge for that 13-year-old mixed breed dog who has, multiple areas. Now I can treat that whole body in 15 minutes. And this is really a lot on owners doing this stuff at home to combine technologies. But where's the evidence, right? So I pulled some papers. This is pulsed electromagnetic field from 1984, okay? Double-blind controlled assessment for rotator cuff tendinitis, showing 65% of patients were symptomless and 5 others much improved, okay? Things that we should be using a ton of, and we have good evidence for. What about using pulsed electromagnetic field for sciatica? Here's a systematic review from 2000, just this year, 2025, right? Safe, beneficial treatment for non-specific low back pain. So easy to do at home, right? For the owners, maybe they can't come in all the time, right? Or we can modify and we can work together on treating these patients. What about combining shockwave and pulsed electromagnetic field? Here's human patients with rotator cuff tendinopathies, very similar to what we talked about tonight with dog shoulders, showing that they actually do better with shockwave and pulsed electromagnetic field than either one of them alone. And now, real quick, Librela and Silencia. Remember that these are monoclonal antibodies against nerve growth factor, NGF. They are contraindicated in pregnant and or lactating animals. They need to be given subcutaneously every 28 days. If you pull the original Silencia efficacy paper, I think something like 67 or 72% of cats improved on Silencia and 56% of cats improved on placebo. Right? So we need to be careful about this. We have low-level evidence for this drug. And we do need to be really cautious about potential adverse events in both dogs and cats. Okay. We do need to be careful about it's only been studied in appendicular osteoarthritis. It is not to be used in neurological conditions. It is not to be used for acute pain. Okay. It is not to be used in a developing fetus. It's not to be used on something, right? We need to be, or a developing animal that's developing its nervous system. And it has not been studied to be combined with an NSAID. So if you're on an NSAID, you shouldn't be on an NSAID and on this drug at the same time. The paper in cats, like I said, right? Placebo group 60% improved on day 14, 61% of the treatment group on day 14. By day 56, 44% of placebo cats are improved and 80% of treatment cats are improved. So yeah, it's a big difference, but remember, they're still getting a lot of placebo effect with this. I do use it for cats. I'm very careful with it, of course, make sure I have the right diagnosis, okay? But I also give them 3 treatments and I say, come back and reassess to make sure we're actually using it and seeing it improve. However, and I'm now starting to see this in cats as well, globally, there's a bunch of us that are seeing significant joint collapse on Librela and or Silencia. Okay? On the left is a normal dog who was never on Librela, who had tarsal instability from a trauma. Dog was an agility dog. It fell off the A-frame the wrong way. It screwed up its joints. The dog on the left never did agility or anything else. It was a pet border collie, and it was completely plantigrade and had to have bilateral pantarsal arthrodesis done. Dog radiograph on the left was when the dog started on Librela for its hip OA, and then 18 months later, you can see there are no hip joints left. 2-year-old Doberman on the left, Librela for, I think, about a year. You can see the radiographs on the right. This is out of Italy. This dog's joints are melting apart. In fact, this dog went for a total hip replacement, and when they took the femoral head and the joint capsule, they sent it to the lab, and this is a copy of the lab report, and as you can see, it's histologically compatible with what's called synovial osteochondromatosis. This is severe degradation of the joint capsule. This is exactly the same adverse event that was seen in human women in the 1990s when this drug was tried to brought to market for humans, causing the FDA to permanently shut down the drug availability period for humans. In fact, this is a 2017 human paper saying maybe we shouldn't be using this at all because the studies in laboratory animals show potential detrimental effects on joint integrity. Not just in the Europe and Americas. This is, pardon me for a sec. This is out of Australia. This is a border collie that was on both Librela and Silencia together. No, sorry. Librela and an NSAID together. You can see this poor dog's hips melted away in the radiograph on the right. In fact, this is out of the University of Illinois. This was a dog who was a small dog, was treated with an extracapsular repair, and was given Librela at the time of its surgery. And you can see that this poor dog's joint melted away. This was not infectious. This was not cancerous. This was within 8 weeks of this dog having an extracapsular repair. And oh, by the way, it wasn't just the operated leg. Here's the unoperated leg. Right? This poor dog wound up being bilateral pelvic limb amputations. Also, I believe came back as synovial osteochondromatosis. This is another one out of the University of Illinois, okay? Knees should not look like this, okay? Only factor here on these is Librela, right? Here's a dog who got 1 dose of Librela 7 days before its TPLO because it went to its GP and they said, oh yeah, let's give you Librela and put you on an NSAID, right? So it got that on August 1st. It had a TPLO on August 7th, or rather on the 12th, rather. And then you can see at 8 weeks, the red arrow on the third image points out that there is no femoral condyle anymore. And then by January, this entire joint has melted apart. This is courtesy of Laurent Guillot out of Los Angeles. He is seeing a ton of these cases in knees, okay? He is one of the few veterinarians in the US who can do a total knee replacement, which is what I think both of these dogs wound up getting, okay? Melting joints, folks. This is the paper by Mike Farrell and a host of others. This is now, that slide I think this now has over 200,000 total views. I made these slides a few weeks ago. This paper was only published in May of this year. This is an independent review, case control study and series of analysis reporting the adverse events for musculoskeletal problems due to Librela globally. I highly suggest you all read it. It's an open access article. Not only are we potentially seeing orthopedic problems, we're also seeing potentially neurological adverse events, such as spontaneous LS disease, which doesn't happen. But you think it's hip OA, we give it Librela without taking radiographs or doing a thorough physical, and what we've actually done is aggravated the LS disease the dog already had. There are also reports of seizures, thoracolumbar paraplegia, rapid cognitive decline, okay? Curtis Dewey and I will have 2 papers submitted this year. We did client surveys, and 50% of dogs had adverse events, 50% did not. The number 1 and 2 things most associated with an adverse event, not taking radiographs and having a normal physical exam. So the dog was completely physically normal and put on Librela, or had known neurological issues with no orthopedic issues and was put on Librela. So please, please, please be good diagnosticians and advocates. Do a solid physical. Remember rule number 1, which is do no harm, and reach out to somebody before you start this drug, right? Figure out what we're actually dealing with first. This is not a first-line defense drug, okay? With that, I thank everybody for their time tonight. I realize I went over a little bit. You've got my direct contact info. My thanks to Zoometica for hosting. And take care, everybody, and have a good night.
Thanks, Dr. Brunke. We'll see you again soon. Everyone, thank you for joining us. We'll see you on the next Zoometica sponsored webinar. Have a great evening.